Good morning, everybody. This is Rich Polin speaking to you from just outside of New York from my home. It's now February 2nd, 2021. Uh, I am delighted to be speaking to all my friends in Hong Kong and appreciate Bill Chan's invitation to ask me to speak this morning. And before I begin, I want to say, and this is the truth, that Hong Kong is one of my favorite cities in the world. It has the great cultures of both Asia and Western culture, has fantastic restaurants, and most importantly, has great people. And I have so many friends in Hong Kong, I can't begin to make a list, but it's a fabulous city. Now, you have to excuse my informality this morning in terms of my dress, but New York is getting about 20 inches of snowfall overnight and today, and which is about 50 centimeters. So I'm going to be out shoveling the snow in a little while. Today, I'm going to be speaking about one of my favorite topics in neonatology, and that is CPAP, or non-invasive ventilation. And I'm going to end the talk by speaking about non-invasive positive pressure ventilation. Now, if you come to my NICU, let me try to advance my slides. Here we go. If you come to my NICU in New York City, and some of you have, you see lots of babies like this. This is one of our many premature babies that are being managed with CPAP. And for the most of babies, of our babies born uh, 28 weeks or even 27 weeks and above, this is how they're managed. Now, if we talk to our nurses about CPAP, they view it as a religion. And some people say, well, CPAP must be a gift from God. I'm not ready to say that. But as a scientist and a believer in evidence based medicine, I can say that effective use of CPAP can decrease the risk of BPD. I put the word substantially in parentheses on this slide because, in our hands, a CPAP does substantially decrease the risk of chronic lung disease. But when I show you the randomized trials, the benefit is not as obvious, although it is significant. And if you want to remember what the secret of CPAP is, there it is. It's the NICU nurse. And although we come to the bedside and examine the babies and talk to our nurses, it's the nurse at the bedside that knows how to troubleshoot CPAP that makes it an effective modality. So here's my outline for today's lecture. I'm going to be speaking about the use of CPAP as the initial mode of respiratory support and why that makes sense, especially as opposed to use of surfactant. Secondly, I'm going to be speaking about how you deliver CPAP and ask the question, does the method you choose to deliver CPAP make a difference in outcomes? And then I'm going to be, at the end of this lecture, speaking about the alternative to CPAP, which is non-invasive positive pressure ventilation, and finally give you some of my own conclusions and recommendations. Let me start off with a concept that sort of underlies this whole lecture about non-invasive ventilation, that if you don't ventilate an infant, it's very hard to cause BPD. And that's why the incidence of BPD is so low in our NICU and other NICUs around the world. Let me start with you a case. This is a 750-gram infant. The initials are DT, born following a 27-week gestation. The infant exhibits some immediate signs of respiratory distress, and the NICU requires 30% oxygen to maintain a saturation of 91%. The PCO2 is just slightly elevated at 52. The chest x-ray looks like RDS with air bronchograms and groundless appearance, and what should be done now. And I always try to choose real cases from our NICU. So I'm going to show you a picture of DT. There he is. Not a good looking baby from my viewpoint. So here are your choices for how you'd like to manage a baby. You can withhold surfactant and place the baby on a form of nasal prong CPAP and just observe the baby. Or you can decide to give surfactant and rapidly extubate the CPAP. And that approach is called INSURE, intubation, surfactant, extubation. Or you can withhold surfactant and use one of the other modalities of non-invasive ventilation, which is non-invasive positive pressure ventilation, NIPPV, or high flow nasal cannula. And for me, just to go back, the choice I would make is A, but I can see some of you choosing B because of the tremendous amount of data showing the effectiveness of surfactant. And this is a meta-analysis looking at the effect of natural surfactants, multiple dosing, prophylactic surfactant, early surfactant. RR is a risk ratio, 95% confidence intervals are shown in the second column. Number needed to treat is in the third column. And the fourth column is interesting because it's the confidence intervals for the number needed to treat. And almost everything on the slide is statistically significant, but you see there's wide confidence intervals for the number needed to treat, as many as 1,000 babies to get a reduction in mortality. Now, if you look at the original surfactant trials, there's two observations which are important. One, they were done in a time when practitioners were not using antenatal steroids. And secondly, infants randomized to the control arms of these trials were routinely ventilated without surfactant rather than receiving CPAP. And as you know, if you ventilate a baby without surfactant, it's likely to cause lung injury or mortality. That's why surfactant was shown to be quite clinically effective. But surfactant's been used for a long time. These are data from the NICHD Neonatal Research Network, published by Barbara Stoll, looking at the use of surfactant therapy from 1993 to 2012. And it's interesting that the numbers continue to go up during that time. And you ask yourself, well, what impact has that had on BPD? And in fact, not very much, because the risk of BPD or incidence of BPD over that time has also increased. So it was Leonardo da Vinci, shown in the top part of this slide, who said, simplicity is the ultimate sophistication. That was also the phrase that Stephen Jobs used, the inventor of the Apple computer. And I'm not so eloquent, and my favorite phrase is use the KISS principle for neonatal intensive care, which is keep it simple, stupid. So I ask you, would you rather use a ventilator like the lower part of this slide with all these knobs and controls, or use something that looks as simple as a baby on CPAP? And this is sort of a tongue-in-cheek question, but sometimes this kind of sophistication is necessary. But for the majority of our babies in our NICU, non-invasive ventilation using CPAP is the most effective approach. So the first question, I've already alluded to this, is the use of CPAP as initial treatment for preterm infants with RDS evidence-based. And as my slide says, it is. There's no question about it. There have been a number of randomized clinical trials. These are the major ones. It does not include the South American trial. And these are the trials which compared now CPAP versus intubation surfactant, with the outcome being death or BPD. And you can see here that the risk ratio is 0.9. There's the confidence intervals. And as I start off my lecture by saying, is that CPAP can substantially reduce the risk of death or BPD, but these numbers are not very impressive, with a confidence interval of 0.98. Therefore, there must be something that has made these data look less impressive that we're doing in New York. And if CPAP is going to be compared to any other respiratory modality, intubation surfactant, Ensure, NIPPV, or high flow nasal cannula, it has to be used optimally. And the question we should ask ourselves, why has CPAP been only marginally better? And here are the reasons which are obvious to me. Inexperience with CPAP in the centers that participate in those randomized clinical trial, and greater skill with other forms of respiratory support like ventilators. I'm going to make the argument that the thresholds for abandoning CPAP were too low. I'll show you some data in a second. In all these trials, there was limited duration of ventilation. And if you don't ventilate a baby for very long, it's hard to cause chronic lung disease. And finally, some CPAP delivery systems may be more effective than others. These are data from Hani Ali. Hani Ali was a fellow in the 80s up to the early 90s in New York, and then went to GW in Washington and brought with him the use of CPAP. And these are data from what he called the pre-CPAP era, which was the late 1990s, and then 3 terciles. These were the duration of each of these was about a year, and looked at 4 outcomes: how often CPAP was being applied, how often the clinicians had failure of CPAP, use of surfactant, and BPD. So in the first year after CPAP was introduced at GW, you can see here that CPAP was applied about 18% of the time, not very much different. CPAP failure jumped up tremendously, up to about 40%. Surfactant use was unchanged, and the incidence of BPD went up. And it wasn't until tercile 3 that many babies, 2/3 of babies, had CPAP applied. The CPAP failure rate went all the way down to 7.4%. I'm sure it continues to decline after that. Use of surfactant went from about 50% in the pre-CPAP area down to 33%, and BPD was reduced by 2/3, from 33% to 11%. So the point is that there is a learning curve by CPAP, and just because you know that it's a benefit to babies does not mean it's going to be initially beneficial in your NICU. And here's one of my other arguments why those studies are not relevant, is that the thresholds for abandoning CPAP were too low. So on this slide, we have the 5 main trials, this time including the South American trial, which was called NeoCOSURE. This was the percent of babies in each of the babies who were randomized to CPAP or intubation and surfactant. And on this column, it's the percent of babies who got surfactant in the CPAP group and control group who got, again, intubation and surfactant routinely. And finally, the FiO2 defining treatment failure. First of all, you can see that each of these trials was not really a comparison of CPAP versus intubation surfactant, because many of the babies in this study in the CPAP arm required intubation, as you can see down the line over here, and many required surfactant. And if you look at the last column over here, at the threshold for saying the baby is failing CPAP, in only one study was a threshold of 60% use. And by the way, that is our threshold for abandoning CPAP in my own NICU. In 2 studies, it was 50%, in 2 studies, 40%. Well, we could argue for a long time what the threshold really should be for abandoning CPAP, but I can tell you that use of that high threshold did not increase morbidity and mortality in our NICU. So we currently use a threshold of 60%. And finally, I mentioned that in all these trials, the duration of ventilation was not very long. In some, it went as long as about 2 weeks. But in the majority of babies ventilated in these studies, ventilation was less than a week. And again, it's hard to show a difference between CPAP and a control arm where babies receive intubation and ventilation and surfactant when you're only ventilating babies for 7 to 14 days. All CPAP devices are not created equally. And there are 3 main devices for using CPAP. One is a threshold resistor exhalation valve, as you might see on a ventilator. We use bubble CPAP, and I'm going to be talking about different varieties of bubble CPAP in just a few moments. And then there are variable flow CPAP devices, the most popular of which is infant flow driver. So I'm going to show you the randomized clinical trials now, and I've deleted out the observational trials of using each of these varieties of CPAP delivery. As you can see here in the study by Yamazello is a comparison of bubble CPAP versus infant flow driver, very small study, and they showed a significant benefit with infant flow driver, but their benefit was not ones we care about very much. Oxygen needs, respiratory rate. We really worry about, or we really think about how CPAP prevents the need for intubation or intubation and surfactant. So that was not significant in this study. And Dr. Yamazello will say it was a very tiny study. He used bubble CPAP with only a single nasal prong, which is probably not optimal. The study in Journal Tropical Pediatrics was a larger study of bubble CPAP versus ventilator-derived CPAP. And in this study, bubble CPAP decreased the percentage of infants requiring conventional mechanical ventilation. This is use of CPAP at the time of birth in babies with RDS. And this slide is the use of CPAP following extubation. The first study compares infant flow driver versus ventilator-derived CPAP, showing a benefit to infant flow driver in decreasing CPAP failure. And the second study is probably the most important one of this whole group. It's a comparison of infant flow driver versus bubble CPAP, a study from Middlesbrough in England. You can see it was quite a large study, 140 babies. And in this study, bubble CPAP was significantly better than infant flow driver. And they also used babies with a mean gestational age of 27 weeks. So let me show you some of their data. On the left part of the slide is a Kaplan-Meier curve, which is looking at the days of CPAP use. The blue is infant flow driver CPAP. The orange is bubble CPAP. And you can see throughout this time period, goes through about 60 days of life, the number of babies failing bubble CPAP was significantly less than infant flow driver. And on the right part of the slide, you're looking at babies who were ventilated for less than 14 days, who were then placed on either bubble CPAP or infant flow driver, and bubble CPAP decreased the rate of post-extubation failure compared to infant flow driver CPAP. It was 14.1% versus 28.6%. So in this large study, infant flow driver was not as efficacious as bubble CPAP. Supporting all that is this animal study, which I think is important. It's by Jane Pillow and Alan Jobe, using their animal model of RDS, which was preterm lambs born at about 133 days gestation. The animals were intubated and randomized to bubble CPAP at two different flow rates, 8 or 12 liters per minute, or CPAP provided by the ventilator. And in this slide, we're looking at the pH of those animals. The bubble CPAP is shown in the orange squares. Constant pressure or ventilator CPAP is shown in the blue circles. And you can see the pH is higher with bubble CPAP. The PCO2 is lower with bubble CPAP than it was with ventilator-derived CPAP. And this is looking at oxygen extraction, comparing the constant pressure CPAP provided by the ventilator and bubble CPAP at two different flow rates, 8 and 12 liters per minute, showing that oxygen extraction is better with the use of bubble CPAP than it is with the ventilator constant pressure CPAP. And this was the conclusion of Dr. Pillow, who said that the more efficient utilization of oxygen in the bubble CPAP group are suggestive of increased airway patency. And Dr. Pillow would use the word noise, that bubble CPAP provides a noise to keep the distal airways opening and allow for better ventilation and better oxygen extraction. It does not exclude that the bubble CPAP is also providing a very small tidal volume, which helps to get rid of CO2. So in terms of CPAP devices conclusions, limited data suggests that ventilator-derived CPAP is not as efficacious as either bubble CPAP or a variable flow device like infant flow driver. Variable flow devices offer no proven benefit over bubble CPAP for management of acute RDS. And then there's this one single large randomized trial comparing use of infant flow driver and bubble CPAP post-extubation, showing a superiority of bubble CPAP. And then is the issue that all bubble CPAP devices may not be equivalent. This is an in vitro study comparing bubble CPAP devices which are available in the United States. On the left here is a homemade device, and for more than 20 years we use this homemade device, which is just a bottle of water containing dilute acetic acid to inhibit bacterial growth. Then there's Fisher-Paykel's commercial device, which is found throughout the world. Another device called Baby Plus, baby spelled B-A-B-I, and then one from Airway's development. This is looking at those small tidal volumes that CPAP is providing, and it's comparing the Fisher-Paykel device, which is shown at the top over here, the homemade device, which is the blue diamonds or turquoise diamonds, and then the two others, Baby Plus and Airways Development. And you can see here that the oscillations or the small tidal volume being produced is highest actually in the Fisher-Paykel device than it is in the homemade device, but it's similar at different as you get up to higher flow rates, but much higher than the other two bubble CPAP systems. Now, the thing you need to remember about the other bubble CPAP systems is they have a diffuser at the end of the expiratory limb, and that diffuser prevents those oscillations or bubbles from providing a small tidal volume. And here's what it looks like if you actually measure the respiratory waveforms. Here again is the homemade device. You can see that the oscillations are quite significant. Here's Fisher-Paykel device, which has the same oscillations, but at a slightly lower frequency. But the two others, Airways Development and Baby Plus, have markedly attenuated oscillations because they have this diffuser at the end of the expiratory limb. Let me talk just for a moment about airway interfaces, and I could spend a whole lecture speaking about this topic. And there are a lot of different interfaces. There are prongs. There are Argyle prongs. We use Hudson prongs in my NICU, but I'm not saying that's the best prong. It's one that works for us. Inca prongs, nasal masks, and then a very popular interface is the RAM nasal cannula. And I don't know whether you're using that in Hong Kong or not, but it's used throughout the world. This is a picture of the RAM cannula. So RAM cannula is very different than CPAP. So RAM cannula, you have forward flow through both sides going to the nasal prongs. There's no inspiratory and expiratory limb. The RAM cannula is placed loosely in the nasal cavity and includes 60 or 70% of the nasal cannula, and the baby breathes out around the prongs. That's opposed to CPAP, and you know that CPAP fits fairly tightly in the nares, and we like to close the mouth so we have very little mouth leak. And it's an interface with minimal dead space to reduce breathing of carbon dioxide. This is what the manufacturer of the RAM nasal cannula says on their website. They classify the RAM cannula as a class 1 device. We are unable to share recommendations beyond the scope of our regulatory classification. Uses beyond nasal oxygen administration are at the discretion of the medical practitioner. We recommend up to 4 liters, which is not a very high flow rate for RAM cannula. Anything beyond that is up to each facility. One of the problems with the RAM cannula, it has a very high resistance. And if you look here, again, this is manufacturer data from the 4 commercial RAM cannulas presently sold in the US, including micro, preemie, newborn, and infant. And you can see here between 4 and 6 liters per minute in the micro, preemie, especially, the resistance of the nasal cannula, of the RAM cannula, goes up significantly. Can the RAM cannula be used to deliver CPAP or NIPPV? Well, maybe, but probably not effectively. I'm going to show you 2 in vivo studies with babies. The first being a comparison of Hudson prongs and the RAM cannula. This is a crossover study of 12 preterm infants. Here's the gestational age at a median postnatal age of about 10 days, comparing the RAM cannula again and Hudson prongs with bubble CPAP. And the Hudson prongs had complete nasal occlusion. They then looked at the intraoral pharyngeal pressure to see how much pressure is being delivered by the RAM cannula and the Hudson prongs. And here's the data. There were this graph here is looking at the difference in CPAP pressure that was set and the amount being delivered. So here's the Hudson prongs. You see the 0 here means that the amount of CPAP being delivered, which is the same as that being set, And here's the ram cannula. It's in fact, it's down by about 2 centimeters of water pressure, showing that the high resistance of the ram cannula prevents effective delivery of high pressures as you get with the Hudson prongs in a bubble CPAP system. And this is another in vivo study looking at NIPPV. And on the left part of the slide, we're looking at 3 kinds of breaths. By the way, these are, again, 14 preterm babies. And we're looking at tidal volumes. The first over here are tidal volumes produced when the baby is taking a breath and the ventilator is being cycled. They're using the servo I ventilator, which you know has a catheter to measure diaphragmatic contractility. So when the baby takes a breath, the ventilator cycles. Over here is the tidal volume you get when the baby is taking a breath, but the ventilator is not cycling. And over here is the ventilator cycling, but the baby is not taking a spontaneous breath. And what you see here is the pressure of the breath that's being generated by the ventilator. Here's inspiratory and expiratory flow. Here is the baby's measuring the baby's contractility of the diaphragm, and you see nothing here. So this is the time that the ventilator is cycling, but the diaphragm is not contracting. And what do we get? 0 tidal volume. So that with the ram cannula, as used in this study, when the baby is not taking a spontaneous breath, there's almost no tidal volume. Next important question is, what's the optimal level of CPAP? Well, it depends on your disease process. Is it RDS or is it TTN? What is the compliance of the lung? What kind of device you are using to deliver CPAP? And what's the volume status of the lung? Lung volumes, as you know, change during the respiratory cycle. Atelectasis is likely to occur at end expiration when pressures are the lowest, especially when surfactant is deficient. So here we're looking at pressure volume curves. And over here on the y-axis is volume, on the x-axis is pressure. And this big curve on top is looking at a healthy lung. So as pressure is increased to a threshold, volumes are increased in the lung, a maximal volume is produced, and then during deflation, the volume remains in the lung, and this is called hysteresis. It's because there's not much atelectasis at the end of expiration. On the other hand, with a surfactant deficient lung, it takes more pressure to open up the lung, not surprisingly, and as during the expiration, hysteresis is missing, and in fact, the lung collapses back down because of atelectasis. The only study I know comparing different CPAP pressures is this one out of Melbourne, Australia, by Badia, Peter Davis, and David Tingay, published in Journal of Pediatrics in 2017, which had 20 preterm babies, less than 32 weeks gestation. And in this population, they had their CPAP increased from 5 up to 10 using 20-minute intervals and then decreased back to baseline. They measured lung volumes using a technique called electrical impedance tomography, which is an experimental method to measure lung volumes. And they showed that increasing CPAP reversed the atelectasis. But once the atelectatic areas were open, lower CPAP pressures sufficed in over 2/3 of the babies. That tells you that initially, during the application of CPAP, you may need higher pressures to open up the lung, but once the lung is opened up, you can generally dial back the pressures back to baseline. Interestingly, there are no effects on hemodynamics with the higher levels of CPAP. Again, these are fairly non-compliant lungs, that's not surprising. There were no effects on CO2 and no effects on oxygenation. Excuse me. No single end-descending pressure will optimize respiratory support. That's pretty clear throughout the respiratory cycle. So initially, you may need higher pressures to promote better oxygenation and ventilation, but afterwards, lower CPAP pressures will suffice. So in the acute phase of RDS, most spontaneously breathing babies will achieve adequate oxygenation and pressures with about 5. And that's sort of our gold standard at Columbia. Greater benefits with non-invasive CPAP uh, may be achieved with pressures ranging from 6 to 8. But those kinds of pressures have not been studied in large populations and may not be entirely safe. So we will go up to 8 in a baby who's not improving their oxygenation, but most of our babies are maintained on 5. And it's important to remember that infants failing CPAP often fail for mechanical reasons and not for insufficient pressure. So the nurse troubleshooting the CPAP at the bedside can often reverse problems with oxygenation. And the last topic on CPAP is how do you wean CPAP? Most babies wean, most babies wean from CPAP at 32 to 33 weeks gestation. And there are 3 weaning methods. One is gradual reduction of the CPAP pressure from 5 to 4 to 3. Secondly, you can suddenly remove CPAP. That's sort of called cold turkey. And the third is sprinting, which you're going to leave the baby off CPAP for 30 minutes every couple of hours and put the baby back on. The criteria used to assess stability between these trials I'm going to show you has varied considerably between the studies. And if you look at overall at the studies, no significant benefit of any one strategy is demonstrable, although gradual reduction of pressure may be more successful with first attempts at weaning, especially in the tinier babies. And these are all the trials I could find. Here's the authors, the year of the study, the number of babies in the trial. The far largest is a study by Jensen, the study design, and the CPAP systems where it was available. And in 4 of the studies, pressure weaning was more successful. Here, 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 and here. In 2 of the studies, it was pressure wean versus sudden wean. And in 2 of the studies, it was pressure wean versus increasing time off for so-called sprinting. In a single study, sudden weaning was more successful than increasing time off. But the data tend to indicate that the pressure wean, going from 5 to 4 and sometimes to 3, is a most effective strategy in getting babies off CPAP. These are our criteria for removing CPAP from babies: at least 30 weeks post-menstrual age, no supplemental oxygen for 48 hours, a PDA can be present but it should be asymptomatic, no bradycardial desaturation episodes requiring intervention, less than 2 bradycardial desaturation episodes in the last 12 hours before the attempt at weaning, greater than 90% saturation on 21% CPAP, and obviously free of infection. And the other important thing is, how long do you leave CPAP on before you attempt to trial off? This is a single study published in 2020 in which they took infants less than 32 weeks gestation receiving bubble CPAP who met predefined criteria for CPAP discontinuation. And they randomized those babies to either discontinuing CPAP at that time or continuing for an additional 2 weeks. And we're looking at FRC, functional residual capacity. Here's the time of randomization. The infants randomized to extended CPAP are shown in the orange. The infants randomized to immediately discontinuation of CPAP are shown in the blue. And here is a 2-week time point after CPAP was discontinued in the one group, showing that FRC was significantly higher. And at the time of discharge in babies that were kept on CPAP just for an additional 2 weeks, the FRC was significantly higher than babies that had immediate discontinuation of CPAP. So here's my conclusions about CPAP. Early use of CPAP with subsequent selective surfactant administration in extremely premature babies results in lower rates of death or BPD compared to treatment with prophylactic or early surfactant. That's a level of evidence 1 recommendation. If you're going to need ventilator support, then early administration of surfactant followed by rapid extubation, if you can do that, is preferable to prolonged ventilation. And finally, I'm going to finish my lecture speaking about NIPPV. Now, NIPPV is nasal intermittent positive pressure ventilation. And theoretically, if you're giving breast to a baby, you're going to achieve more effective ventilation. But I'm not sure that's true because most NIPPV breaths are not transmitted to the lower airways. What they do provide is a higher mean airway pressure. So here are mean airway pressures with normal breathing. Here are pressures you get with CPAP. And here is a pressure you might get with bilevel CPAP, a form of NIPPV, in which the mean airway pressure is significantly increased. But I'm going to make the argument that these breaths over here, which look like they should ventilate babies, are not being transmitted. This is a study out of Melbourne, Australia, by Peter Davis's group, looking at a form of NIPPV, which uses synchronized breaths. So in the middle row over here are the baby's breaths. On the bottom row is the synchrony of the ventilator, which you can see follows the baby's breaths extremely well. But you look over here, we're looking at tidal volume. And in fact, in only a few of these breaths are tidal volumes transmitted. Most of the time that the baby's getting synchronized NIPPV, the breaths are not being transmitted. So this is the most recent meta-analysis comparing NIPPV or CPAP for preterm babies with RDS. And the meta-analysis actually says, and these are 10 trials with over 1,000 babies, a statistically and clinically significant reduction in the incidence of respiratory failure. Here is the risk ratio, 0.65. Here are the confidence intervals. It also significantly reduced the risk of needing intubation. Again, the risk ratio and confidence intervals. But there is no significant benefit of NIPPV on chronic lung disease or mortality. I'm going to make the argument that these benefits of NIPPV were on oxygenation and not on ventilation. In fact, this is a very recent study published in Journal of Pediatrics in 2020, and it was a secondary analysis of the largest randomized clinical trial to date looking at NIPPV or CPAP, and that was the study of Haresh Kirpalani. And they only included in this study infants that were never intubated. And failure was defined as infants never ventilated in the first 7 days after randomization. And we're looking at the proportion of remaining on non-invasive ventilation in the NIPPV group and the nasal CPAP group, and it was not significantly different. So again, this is a retrospective data of the large study by Kirpalani showing no difference in NIPPV or just plain old bubble CPAP in infants that were randomized to those two arms. Now here are the randomized clinical trials for post-extubation comparing NIPPV or CPAP. Several of the studies showed a significant benefit for NIPPV. All of those studies, though, were studies in which they used synchronized NIPPV and not non-synchronized NIPPV. And here's the meta-analysis showing, again, a benefit, a clinically significant reduction in the risk of meeting extubation failure or the need for reintubation. No significant benefit for chronic lung disease or mortality. And they say the synchronization may be important. Well, I'm going to say synchronization is very important because all the studies showing benefit used synchronized NIPPV. And finally, my last slide says that preterm babies with RDS weighing less than 1,500 grams should be allowed time to demonstrate if they can achieve acceptable ventilation and oxygenation on CPAP. During that time period, these infants must be monitored closely. If ventilation is not improving, and for us that means a pH less than 7.2 and a PC2 greater than 65, or the oxygenation is inadequate with an FiO2 of 40 to 60%, these infants should be intubated. We would use 60% in our NICU, but other centers might use 40% as a threshold to say that CPAP is not being effective. And two questions: should babies less than 26 weeks gestation, where CPAP fails much more frequently, receive prophylactic surfactant? I'm not sure. Is there a role for aerosolized surfactant? I'm also not sure. So I'd like to again thank Bill for the invitation to speak to you all today. Uh, my email address for those of you who have questions, because this is not a live lecture, is rap32@columbia.edu. And I'm delighted to respond to any of you who have questions about use of CPAP in your NICU. Thank you very much. Bye-bye.